Probably we can start. Good morning, everyone. Thank you very much that you decided to join our satellite session. And today we are going to talk about newly developed and published recently consolidated guidelines on prevention, diagnosis, treatment and care for key populations. But these new guidelines, which is probably the most interesting point, is concerning not only HIV as previously, but also viral hepatitis and STIs. And today we have a really great panel of speakers. Some of them are joining online and will make presentations online, but some of them will join the panel here in person. And I would like to introduce everyone. So we have online joining Keith Sabin, Senior Advisor for Epidemiology with Strategic Information to End Inequalities Team of the Data for Impact Division of UNAIDS. Keith, we are very glad that you will be able to join us. Welcome. We have Antons Mozalevskis, Technical Officer on Key Populations from WHO Global HIV, Hepatitis and STIs programs in Geneva. Antons, we are grateful that not only you are joining, but for all your work that you've been doing in order to prepare this session. Welcome. We have Annie Madden, Project Lead at the International Network of People Who Use Drugs. Annie, welcome to our session. And we have three panelists here in the room. It's Juliet Del Amo, Director of Division of HIV, STI, Viral Hepatitis and TB Control, Ministry of Health, Spain. Thank you very much for joining us. We have Mira Sauranbayeva from Almaty, Kazakhstan, Project Director for Almaty Model for HIV Epidemic Control at ICAP at Columbia University, and she's Deputy Chair of CCM in Kazakhstan, Country Coordination Mechanism. And of course we have Carrie James, Chief Executive of the World Hepatitis Alliance. Carrie, very glad to see you. We know that just after our session, there will be a special session organized by the World Hepatitis Alliance, so we will be in time in order to join this session later. But so let's start, not to waste time. I haven't introduced myself. I am Slava, or Vyacheslav Grankov, and I'm representing here Joint Infectious Disease Unit of the WHO European Regional Office. So we are going to start with the online presentation made by Keith about ending AIDS by 2030 and why it is important to prioritize key populations. Keith, the floor is yours. By the way, dear colleagues, you can choose either presenting and moving slides by yourself, or you can ask our technical team, whatever you prefer. Probably for easier presentation, it would be better if you share your screen and make slides, moving slides by yourself. Yeah. But how? Yeah, perfect. We can see the first slide, Keith.
Okay, thank you. And I take it you hear me well enough. So thank you very much, Slava, for your kind introduction, and Antons for the invitation. Let me just, there we go. So I was asked to address this, and I think, as you all know, we have very but I want to be clear that there are two ways to perceive this. One is a traditional public health approach, which tends to be very utilitarian. And it asks the question, can we act and achieve these goals without addressing every group. And contrast that to the rights approach, where we want to address all targets to all possible groups that are affected by an epidemic. And that is more of an equity approach. And at UNAIDS and in the global strategy to address AIDS as a global health threat, we have taken the equity approach. So I'm not going to focus too much on the quantitative. And I think it's worth reflecting on the words that Mahatma Gandhi said, that we should judge a society by how it populations. And to that, and I can assure you, though it's not on the graph, we won't achieve the target for 2030 either. We are not on a glide path to success. We must bend the trajectory if we are going to reach that target. We are closer to the target for AIDS deaths. Nonetheless, it still requires action, affirmative action, to reach that target. Now, coming to the idea of whether or not, and I don't think it's really a question of whether or not, but how do we address key populations, and are we doing enough to get there, to reach those targets, and what happens if we don't? So this is the distribution of new HIV infections in 2021 as estimated by us at UNAIDS. And you can see very clearly that almost 70% of new infections in 2021 can be attributed to key population communities and their sex partners. While some might question, well, why do we need to do this? Why can't we focus on the broader population and hope that everybody is sucked up into that response? Let me just remind that the Sustainable Development Goal that addresses HIV explicitly asks for disaggregations by key populations. And so we are obligated, and the countries have agreed to be obligated, to report and address the epidemic in each of the key populations. Now, of course, the risk is not universally similar. It's high everywhere, but we can see in this, the global distribution, if we break it down between sub-Saharan Africa, where we have most of the generalized epidemics in the world, and then the rest of the world, we can see that in sub-Saharan Africa, we're still talking about roughly half of all new infections being between and among members of key population communities. And then in the rest of the world, it stretches to close to 90%. So it's really important that if we are to reduce new infections, we have to address the infections among key populations, because their risks are, epidemiologically speaking, out of sight. We do not see risks of 15 to 30 times greater than the rest of the population for almost any communicable disease. But we do see that among the key populations when it comes to HIV. Now, yes, we have been addressing key populations in the global response for some time, but I would pose to you that we have been doing so unsuccessfully. These changes in incidence over a decade suggest that there has been virtually no change. Statistically speaking, there is no change among female sex workers, people who inject drugs, and transgender people. And even worse, the epidemic has expanded among gay men and other men who have sex with men. So we are, in fact, while we may be succeeding elsewhere, we are failing among key populations at a global level. Part of the problem, as I view it, is that countries are still not counting or willing to count the numbers of people who are members of these key populations. Very briefly, the light green at the bottom of each of these bar charts reflects the number of members of each population that are estimated by the governments of those countries. The orange and the darker green at the top reflect those members of those communities that are completely omitted from the size estimates in those countries. So if we're not counting the members of those communities, and the dark green are those who are truly not counted at all, not just an underestimate, then how can we possibly effectively address those communities and their needs? And what's more, what makes this even more difficult is that very often the risks begin at young ages. And we see this among adolescent girls and young women in sub-Saharan Africa, and that's a major talking point, certainly for UNAIDS and for many others. What we don't hear mentioned is the risk faced by young key populations, and that risk is appreciable. And these are just a sampling of articles across 4 different continents where we see very high risk among very young people in these communities. So to begin to address this, UNAIDS and the global community have set targets that are differentiated by risk. And while I only showed the differentiation of risk for PrEP use here, I'm simply using that as an example. And to begin to address that, we have estimated the numbers of HIV-free individuals in the key population communities for most countries in the world, and those numbers are appreciable, and they include some estimation of imputation of numbers who are missing from the official size estimates in countries. And when we tally up all of the numbers of people who require services, whether PrEP or condom distribution or needle and syringe programs, those numbers are appreciable. And we're looking at roughly 1.3 billion people in need of prevention services in the current situation. Just to focus in on PrEP, because this is the latest, greatest hope we have, this is the expansion of people who have taken PrEP at least once in the calendar year depicted. So we see a very rapid rise in East and Southern Africa. And keep in mind that this is during COVID that this expansion has occurred. But a lot of this expansion occurs in 1 or 2 countries. And it is still not at the numbers that we need to see. Similarly, we see a little bit of a blip jumping up in West and Central Africa, which gives us cause for hope. And then, of course, West and Central Europe and North America. It's a little plateaued, but we can attribute some of that to the shutdowns of COVID. But here we see how far short we are falling for PrEP expansion relative to the targets that have been set through UNAIDS modeling done by UNAIDS and others, with the red dots reflecting the targets. Also, just looking at more other prevention services, you can find this in the Global AIDS update from July. The colored triangles or pyramids reflect the targets for each service, each prevention service for each population. So we have sex workers in the light blue on the upper left, and then men who have sex with men on the upper right-hand side, people who inject drugs on the lower left-hand side, and then transgender people on the lower right-hand side. When you can see the color of the underlying pyramid, that's where we are falling short of our prevention targets. It's the clear shapes that are the actual achievements, the median coverage in those countries that do report. And you can see here where we are falling short of getting people tested so that they understand their HIV status. So we have work to do here. It's a little better than other places, but we've seen men who have sex with men do not test where same-sex behaviors are criminalized. That is a major issue for us to address. When we do get people tested, and here in Zimbabwe, we can show the shortfall between men who have sex with men and transgender people being tested compared to the rest of the population.
Keith,
yeah, I'm almost,
sorry,
2 more slides.
Sorry, no, sorry. We stopped seeing your presentation, slides somehow.
Slides are not moving?
No, we don't see the slides. I don't know whether it's technical.
Oh, you don't see it at all?
I can see them in Zoom.
Okay.
It's
probably it's a technical problem here. Yeah, we will try to resolve.
I'll talk a little bit more about the slide
okay.
in that case while they address that. Sorry. So right now I am showing the treatment cascade for Zimbabwe among the total population compared to gay men and other men who have sex with men and transgender women and genderqueer people. And what we see is that the total adult population has achieved the 2025 target in Zimbabwe in 2019, while men who have sex with men and transgender women are falling well short of that target. However, when it comes to treatment and viral load suppression, all the populations are roughly equal. So the shortfall is in the HIV testing realm. I'm switching slides. I'm now showing a slide that depicts the high levels of violence, sexual and other violence focused against key populations and how far short we are falling from the 2025 target. And the next slide shows the number of countries that are criminalizing different behaviors associated with the different key populations. And again, how far short we are falling from the 2025 targets of decriminalizing behavior associated with key population communities. And then I show a slide of the shortfall of funding in the different key populations compared to everybody else. And I will close by saying what I feel the steps are that we need to take. We can achieve our 2030 targets, but only if we can expand prevention services for all key populations, among other populations. We must expand HIV testing and treatment opportunities and uptake among key populations. And this can only happen if laws and policies that are protective and supportive are adopted in communities, and that stigma and violence toward the different communities are reduced as close to nil as possible. And this will only happen if countries make serious commitments to address key populations, which include budgetary commitments and admitting that these populations actually exist in their countries and then counting them. And then I close with some links to resources. So I'll stop there and hopefully we'll share the slides. So I apologize for the technical glitch.
Thank you very much, Keith. Thank you very much for your great presentation. In just a few minutes, we had a very good overview. Do you have any questions from the audience to Keith? No? I've prepared a question for you, Keith, not very much straightforward, probably. So you've been working in on HIV surveillance and specifically among key populations for 3 decades. And obviously, since 80s or 90s, our perception of HIV and HIV infection has changed dramatically from fatal disease to chronic disease, manageable disease. But in terms of key populations' behavior, their risks, their tendencies, have they changed as much as HIV infection, or we still have pretty much the same risk factors, the same behavior. What do you think from your perspective? Thank you.
Yeah, I think the gray in the beard gives the lie to my 3 decades. You know, I started working in this field in New York City in the early 90s. And at that time, probably the biggest risk we were talking about was crack cocaine and how that affected heterosexual transmission. I mean, we still didn't understand a lot. There was still terrible discrimination against Haitians because it was misunderstood how transmission was occurring. In New York, the biggest concerns were crack cocaine in some parts of the city, injection drug use primarily of heroin in other parts of the city. And then the most impacted population that was visible was, of course, the gay community. You know, it was a time when I was losing friends, as many of us were at that time. And it's one of the reasons that, you know, it was the public health crisis of that generation. And I think what's changed, I think the risk behaviors have ebbed and flowed. We've seen injection of lots of different drugs, of changing over time. We've seen party drugs move from cocaine to methamphetamine and other kinds of uppers. And now we talk about drug-influenced sexual behaviors among men who have sex with men, which is the same conversation we were having in the 80s and 90s. It was just cocaine at that time. Now it's something else. So I think the behaviors have changed only minimally around the edges. I think PrEP has been the biggest influencer in many settings. I mean, there are a lot of settings where condom use has never been picked up, but PrEP makes it now acceptable to not use condoms. U equals U, of course, that wasn't even, you know, it was a dream when I started. We didn't have AZT yet when I first began working. And that really changed everything. I mean, there are people, you know, who were on death's door, and that, you know, and then the Lazarus effect, as we used to call it. People came back from the dead. And so, yeah, I don't really reflect back that much. So I thank you for the question. But unfortunately, I'd have to say that we're still addressing the same behaviors with the same risks for acquisition. And I think the community involvement that has grown from the early 80s through the 90s to a fully mature community response today, I think that has been nothing short of miraculous as well. And you know, we need to see that expand beyond the HIV world. And we are seeing that. We're seeing that for other health responses and other responses around that the global population is facing.
Yeah. Thank you, Keith. Thank you very much. And we are moving to our next speaker, to Anton Smozalewskis, who will present actually consolidated guidelines and will tell us what actually is new in these guidelines compared to the previous one. And probably he will touch the behavioral recommendations regarding changing behavior. I was actually very interested when I saw for the first time that WHO guidelines do not recommend interventions aimed at changing behavior. Yeah. So probably Anton's also touches this issue. Please go ahead, Anton. The floor is yours.
I think I was out for a second. Can you hear me now?
Yes, we can hear you.
Okay, I'll
You
share.
will be presenting from your side, the presentation?
Yes,
okay.
yes. I was planning that, then something happened to the Zoom. So can you see now? Yeah.
No, we don't see your presentation. We can see you, we can hear you, but don't see the slides.
We do see it on Zoom.
You see, the same happened during your presentation, in the middle of it, Probably we can start presentation from our side, and Anton's will be telling next slide, and we will be moving them, in this more traditional way, or probably easier way.
Should I stop sharing in that case?
Yeah, you can stop sharing, probably, your slides, and we will put a presentation from here with the help of our technical stuff. Oh, yes, we can see it. We can see it, your first slide, title slide.
I don't think we don't have it now.
I think there's some delay. I think there's some delay in the room, so...
So Antons, maybe if you share your slides on the screen as well, then we'll see your slides, you'll see your slides, and the room will see the slides being shown locally.
Okay,
anyways, that works.
I think I will start, and hopefully the audience in the room will also see. So good morning, everyone, and especially those in the room, and my apologies, I couldn't manage to attend in person this time, but I hope you have a great conference, and also thanks to Slava for helping with moderating this session. So in this brief presentation, I'll try to stick to the time so we are not late for the next session. I'll try to present the updates in the WHO key population guidelines. As you know, first we published the guidelines on key population in 2014, then there was an update in 2016, and this year we have published, after several years of work of the guideline development group, and many of you have contributed to this process. So this is for the first time that we are addressing HIV, hepatitis, and STI.
Next slide.
Why we need prioritize key population, I think Keith explained it quite clearly from the perspective of HIV, why key populations are actually in the center of the response to the HIV epidemic, but the same is also for viral hepatitis and STI. We know that key populations are defined as, we all know the 5 key populations, they are at higher risk, or they are more affected by not only by HIV, but also by viral hepatitis and many other STIs. And this is not because only due biological factors, social factors. There's also a lot of a big role of stigma and resulting in criminalization and other human rights abuses that also leads to poverty, unemployment. There is also a component of other confounding factors for discrimination, such as race, disability, and education. So this all leads to reduced access to prevention, testing, and treatment services. So those who most need actually those services, they have highest barriers for accessing those. So, the theory of change, how to achieve elimination of hepatitis and ending AIDS by 2030, is that we have to reduce structural barriers such as stigma and discrimination, the criminalization, and other human rights violation. We also need to empower communities, improve service delivery, including decentralization and task sharing, integration, and online services. Provide evidence-based, people-centered interventions, because these are where investments will be most effective, and find priority, in fact, impactful packages of interventions. Slava, just to check, do you see any slides in the room?
Well, I have the possibility to move your slides also, so
Okay.
It's, the next slide, how we can optimize.
Next slide is on the methodology, of the updating the guidelines. So of course, we reviewed already what exists. We looked, because this is a consolidated guidelines, we looked in all the published documents, what already exists. Then there was a process of identifying where are the gaps, what needs to be newly developed and what needs to be updated. Then we performed the evidence review, including the usual literature review, but also in this case, we worked together, or actually we contracted the networks of the community organizations which conducted the qualitative research on preferences and on values and preferences, which will be presented a bit later. And we developed new and updated recommendations. And also in this case, we developed the prioritized packages. So is this also a little bit new in the guidelines? So we have grouped the interventions into 4 different groups, and 3 of them are essential in all settings, and these include enabling interventions, interventions for impact, which are health interventions, which are necessary for having an impact on HIV, hepatitis, and STI incidence and prevalence. And the 3rd group is essential for broader health, which might not have direct impact on HIV, hepatitis, and STI, but they are of high priority for the populations, and they are needed for overall health. And the other group is supportive interventions, which create demand, provide information, and education. So in the core of the interventions, so essential for impact are enabling interventions which go beyond the health sector, and these include removing punitive laws, policies, and practices. So basically, we're talking about decriminalization of key populations and decriminalization of behaviors or in case of sex workers, in case of decriminalizations of sex work, reducing stigma and discrimination in health sector and beyond, empowering communities, and addressing violence. So the other package or other group of interventions are so-called health interventions, and they we all know them, and I'm not going to go into details, and they fall under 3 different groups: and prevention, diagnosis, and treatment. And prevention package includes, of course, harm reduction, which is the essential intervention for a reduction of HIV, but also hepatitis incidence. Condoms, pre-exposure and post-exposure, prevention of vertical transmission, hepatitis B vaccination, and also as a separate intervention, we are also looking at addressing chemsex because it requires a comprehensive response. And finally, the group of essential interventions for broader health, which include contraception and other pregnancy and conception and pregnancy care, gender affirming care for trans and gender diverse people, providing mental health services, TB screening, and addressing alcohol and substance use. So coming to the new recommendations, or in this case, it's a new good practice statement. This might look a little bit confusing from the first sign, but the evidence shows that planning and implementing response for HIV, hepatitis, and STIs, policymakers and providers should be aware that counseling behavior interventions that aim to change behavior to reduce risk associated with infections have not been shown to have an effect on HIV, hepatitis, and STI incidence, nor on risk behaviors. So this is important to understand that we should not fund, or we should not invest in the interventions that aim at changing behaviors. However, counseling and information sharing, which is not aiming at changing behaviors, can be a key component of engagement with the key populations, and when provided, should be in non-judgmental manner across other prevention interventions with involvement of peers. We also developed a new good practice statement on addressing chemsex, which requires comprehensive and non-judgmental and person-centered approach, and that can include also integrated sexual and reproductive health, mental health services, access to harm reduction, and linkages to other evidence-based prevention, diagnostic, and treatment interventions. So as I mentioned, these guidelines are consolidated across different disease areas. So we have new recommendations specific to hepatitis C. One is related on screening or testing for hepatitis C reinfection. So it says that people at ongoing risks and a history of treatment-induced or spontaneous clearance of HCV infection may be offered 3 to 6 monthly testing for presence of HCV viremia. So directly for presence of infection. So it's testing for hepatitis C reinfection, which is important because we know that there is some risk of reinfection for hepatitis C among key populations, specifically people who inject drugs. And the second one is related to start of anti-hepatitis C treatment with direct-acting antivirals, and it should be offered without delay to people with recently acquired HCV infection and ongoing risks. So basically, it's a recommendation for treatment of recent infections, or used to call acute hepatitis C. So we don't have to wait for 6 months or longer to see whether infection will become chronic or not. So we should offer treatment as soon as possible. There are a few interventions related to service delivery, or few recommendations related to service delivery. And we know that service delivery is the key in response, and it should be diversified and should reach as many people as possible. So there is a recommendation on including peer navigations to support people from key population to start HIV, hepatitis, and STI treatment and remaining in care. And peer navigators' role is key to assist key population members to access health services. And they require adequate remuneration, recognition, training, and support to fulfill their role. Finally, there is also recommendation on online interventions for key populations. They should be offered as an additional option while ensure data security and confidentiality protected. So important is to provide the choice, because online services could be suitable for some people, but but conventional interventions should also be available. They should not, virtual intervention should not replace face-to-face services. And also in collaboration with UNAIDS, we have developed also a policy brief which provides more details on development and implementation of virtual interventions, and you can address them online. There are also some certain specific consideration for young key populations, as Keith mentioned in his presentations. There are specific needs that have to be addressed. These includes making services supportive, making use of peer-based and peer-led initiatives, development of appropriate information and education services, and also educating healthcare providers, people working in welfare on specific needs of the young key populations. With this, I would like to thank you, and also thank all the huge amount of people who were involved, including the key population networks, guideline development groups, and also external review group. Thank you very much.
Thank you very much, Antons. Any questions from the audience to Antons regarding new recommendations? Then I will ask also a question to Antons. So we have already started that our session with mentioning that these new consolidated guidelines addressing not only HIV as previously, but also viral hepatitis and STIs. And I know that Antons has been working both with key populations for many years, but also with viral hepatitis. So, Antons, from your perspective, your perception, will this change be more important for delivering more comprehensive services for key populations, or it will have more significant impact on viral hepatitis services? I know that you will answer both, but yeah, but probably you can reflect a bit. Yeah, please.
Yeah, I think both, as you mentioned, of course, both. But whether this will become a reality, that depends on all of us. And we know that globally, also by partners and also by WHO, we have been promoted this integrated and person-centered approach. First of all, that will benefit the people, and also the global strategies and the regional action plan. They also address both HIV, hepatitis, and STI together, which in the same time also keeping the focus on disease areas, because it's important not to forget, because we also know that HIV services have been are developed and more funded in many countries. So maybe addressing in an integrated way, it will help to strengthen also hepatitis response and STI response, but in the same time, of course, the using the people-centered approach, so people don't have to run from one place to another, and their needs are addressed in a comprehensive way. I think it's also very important. And yeah, I also wanted to mention that there's a lot of good developments, including in the Global Fund. As you know, the new HIV information notes includes providing hepatitis services not only in the context of co-infection as it was previously, but also providing treatment for people who inject drugs. And I think it's a very important achievement, which is a result of many years of advocacy by the communities and also by partners, including WHO. So I think there is a lot of work to be done, but we see also good development. I'm sure Carrie will address this question more during the discussion. So, but I hope I answered you.
Yes, fully. Thank you very much, Antons. Yeah. So we are moving to our next speaker, Annie Madden, for the development of new WHO consolidated guidelines. WHO commissioned 4 networks of global networks of key population to undertake new qualitative research on values and preferences among their networks. And so Annie was also principal investigator on the input arm of WHO key populations and value preferences studies. So Annie, the floor is yours. We are very glad that you were able to join us. I don't know from which part of the globe you are joining us today.
From Sydney, Australia.
Sydney, yeah, great, thank you.
So thank you. It's great to be here. So have you got my slides there in the room as well? And I can ask you to...
We don't see, but we can put your presentation, and I can move the slides like...
You'll move for me?
Yeah,
okay.
Now it's title slide, yeah. Mm-hmm.
Ethan, Antons, you've got mine in Zoom? Yeah, okay, great. All right, so thank you for inviting me here today. My name's Annie Madden, Dr. Annie Madden, and I'm from the International Network of People Who Use Drugs, known as Int'l. And I'm today going to be presenting on behalf of the 4 global key population networks that were involved in the values and preferences qualitative research for the development of the guidelines. And those networks are listed here down my first title slide. So that's GATE, which is the transgender communities global network, Int'l, which is the International Network of People Who Use Drugs, MPACT, which is representing gay men and MSM, and NSWP, which is also the global network of sex worker projects. So all of those networks have been involved in conducting this research. Next slide. So I'm just going to take you through very quickly through some of the rationale and objectives behind the research, touch a little bit on some of the methodology issues, run through participant demographics, and then touch on some of the key results and some concluding remarks. Next slide, please. In terms of rationale and objectives, really, the key objective of this values and preferences research was to ensure that the WHO recommendations are informed by the values, preferences, and lived experiences of those who are the intended beneficiaries of the guidelines. And so, you know, the rationale behind it was to provide insights into the values and preferences of key populations. And while we looked at issues like the health priorities of each of the key populations, we didn't only look at those issues, we also looked at some of the sort of contextual issues, if you like, in particular structural barriers that prevent access to services, and also some of the enabling interventions that might help to address some of those structural barriers. This research was significant. The guidelines, as we've mentioned, are significant because they have included viral hepatitis for the first time. But this research itself was significant because it is the first time that values and preferences research, community-led values and preferences research, has been included in the guidelines development process, in addition to the review of clinical evidence that would typically be part of a guidelines development process like this. Next slide, please. In terms of methodology, so each of the networks recruited participants with the specific purpose of speaking with people in each of the regions who would have views on values and preferences around HIV, viral hepatitis and STI services and programs. The eligibility criteria was that people needed to be over 18, speak English, French, Spanish or Russian, and needed to be a member of the key population of concern for the particular network. In terms of data collection approaches, so basically there were two primary investigators for each of the global key population networks. I was one of the primary investigators for input. And then each of the networks commissioned regionally based community experts as consultants to then conduct the research on the ground, overseen by the primary investigators. The data was collected through focus group discussions. Most of those were done virtually, and semi-structured interviews also done virtually. In terms of analysis, data analysis, once all of the key population networks had separately collected their data, we then came together and collated the data across the networks, thematically coded that data and analysed it. And we did that using a shared framework that we had developed prior to the data collection, so that we knew that we were going to be able to come back together and collate the data and make sort of analyses across the data in terms of commonalities, but also to identify outliers where there might be differences between each of the networks as well. Next slide, please. So at a glance, what we can say is that there were 61 semi-structured interviews done, 32 separate focus group discussions, a total of 229 participants across 69 countries from all 6 WHO regions. So quite good reach and coverage in terms of giving us a good picture from each of the key population networks. Next slide, please. Further participant demographics show that there you can see the breakdown of the numbers of participants across the 6 WHO population regions. Also, in terms of country income, you can see that the majority of countries were low or middle income countries, and the participants, the gender representation is quite well balanced across various genders. Next slide, please, going into key results. So go to the following slide. Looking at perceptions of behavioural interventions and their impacts, there was a very strong preference that came out across all of the key population networks for peer-based and community-led tailored behavioural interventions. And the key reasons that people gave for having a preference and valuing those types of interventions was because they felt they felt safe, they trusted those interventions, they were confidential, and accessible, and the accessible largely related to people saying because they felt they were non-judgmental, and that was really important to people. Peer-led counselling, outreach, education and information exchange was considered more effective, and efficacy of behavioural interventions was people very much spoke to the efficacy of behavioural interventions being reduced by structural barriers and drivers of vulnerability. And in particular here, people were talking about the impact, the negative impact of criminalisation on people's access to services and the structural barriers that creates, and the ongoing nature of quite intense stigma and discrimination and human rights violations that again prevent access to services and have very negative impacts on people's overall health, well-being and their rights. Next slide, please. In terms of HCV testing and treatment, there was actually very limited knowledge of hepatitis C testing and treatment observed among most participants, actually, with the exception of participants from Int'l, which, given that Int'l represents people who, in this case, we were talking to people who inject drugs, that's probably not surprising that they did have a reasonable level of literacy around hepatitis C testing and treatment. But among all the other networks, there was very limited knowledge. Awareness of and access to pan-genotypic direct-acting antiviral treatment varied across the key population networks, and there were significant barriers to hepatitis C treatment from due to issues of cost, abstinence requirements requiring people to cease drug use before they would be provided with access to hepatitis C treatment, delays in access to testing and treatment, again, stigma and discrimination, and lack of political will to make resourcing and services available, and information, problems with access to information. Next slide, please. In terms of STI prevention, testing and treatment, there was little knowledge surrounding pooled sampling methods for gonorrhea and chlamydia screening. This was particularly among the impact and the sex worker key populations. There was emphasis on improving access to rights-based STI prevention services as opposed to periodic presumptive testing. Again, this was specifically among the impact and NSWP participants. And there was a preference for community-led services, largely due, again, as I'd mentioned earlier, to stigma and discrimination, criminalisation, violence and marginalisation in mainstream health settings. Next slide, please. In terms of HIV prevention, the preferences in terms of interventions and services and approaches varied by group and individual, and this really sort of suggested the need for a very tailored approach and a diverse range of options being available to meet people's needs. External condoms and lubricant, opioid agonist treatment, needle and syringe programs and other harm reduction supplies was seen by participants as key and critical pillars of HIV prevention. HIV PEP and PrEP was acknowledged as effective, but largely inaccessible for most of the key populations, which has already been mentioned by Keith. Insufficient information and misinformation surrounding HIV PrEP was across all of the communities. These issues were raised by all communities, and their preferred settings for HIV prevention were mobile clinics, harm reduction settings, peer outreach, and drop-in centres. Next slide, please. Just in terms of structural barriers, to finish with that, basically, in terms talking to participants about in more detail about what some of the structural barriers to HIV, STI and hepatitis C services were, in terms of stigma and discrimination, that was looking like poor treatment from providers, denial of treatment, breaches of confidentiality, violence, abuse, and also internalized stigma that was preventing people coming forward and the impacts of that. In terms of criminalisation, that was looking like fears of legal repercussions when accessing services, punitive policies and practices where, for example, using condoms or used injecting supplies as evidence in court cases. So that was then acting as a barrier to people coming forward. And exclusion from funding and state health responses. So some services, peer-run services, not being funded, being excluded from funded because of it being a criminalised behaviour or practice or criminalised community. And then there was also a lack of legal gender recognition, and this looked like a lack of gender-affirming care and barriers to education, employment and housing. Next slide, please. Some of the enabling interventions that participants felt could address some of those previously mentioned structural barriers were things like policy reform, anti-violence measures, better funding and resources, and more initiatives towards community empowerment. So next slide, please, final slide. Just to sum up, community-led values and preferences research can provide important new and additional insights for guideline review and development processes. Communities know what is needed and what works, but are often not adequately resourced to voice their needs or to respond effectively. And these types of partnership approaches between WHO and key population networks provide an opportunity to ensure that technical guidelines are effective and meet the needs of the communities they are designed to benefit. Thank you.
Thank you. Thank you very much, Annie. Because we are running out of time, so I will not ask all my questions, but one question still I will ask. What about next phases? I mean, implementation of the guidelines, monitoring, evaluation. Will your network will be involved at some stages? Do you have any kind of agreements with WHO? Please, reflect about
that. Look, I mean, there's a long way to go on that. And obviously doing these types of presentations, and we've done a number of these presentations elsewhere as well, that's really great for raising awareness around the value of key populations and values and preferences research. I think where in terms of implementation, you know, communities have spoken. They've said they really value and prefer community-led and peer-based approaches. So there really needs, in terms of implementation, to be funding and resourcing at the local levels for those services to be able to be provided in the ways that community want them. But finally, what I would say in terms of monitoring, we all know that community-led monitoring is a real buzzword at the moment. Everyone's talking about what it is and what it isn't. But I think that, you know, that is really where we need to be heading towards in terms of monitoring the implementation of the guidelines and the provision and evaluation of service delivery. It has to be about communities having a voice and being able to not just be asked what they think or what they need by some external stakeholder, but actually generating their own data, speaking from their own data, and then actually having that, presenting that and having that taken seriously as an accountability mechanism. That's what's actually going to change things. We have to hold funders, service providers, and implementers to account. And the only way to do that is to build the capacity and resource community to do community-led monitoring in these areas. Yeah.
Thank you very much, Annie. Thank you very much. And now I will ask my colleagues to join here in the panel, Julia, Carrie, Mira. And we will talk a little bit. I will start probably with Carrie, considering that they will have a session now, because I don't want, of course, you to miss it, So my question to you would be actually continuation for what we already started discussing with Anton's. So we've always been aware about significant impact that key population have on viral hepatitis epidemic, and how important to integrate the services for key populations and services for viral hepatitis into services existing. So now we have these integrated, consolidated guidelines. What, in your perspective, we should do next? What would be the most important in order to actually to make changes, to implement them?
Sure. Thank you very much, and thanks for the invite. I mean, I think it's so great to have these new integrated guidelines, not just the key populations, but also the GHSS. So it's really recognizing what community-based organizations do. I mean, we look after our communities, right? And we might get the majority of our funding from one kind of funder concerned with one health concern or another, but that's very rarely the only thing that organizations do, right? We really try to serve the whole of the person and the whole of the community, and we always have. So this is kind of a recognition of that reality. So I think it's, in terms of WHO, it's continuing to walk the talk, right? To really take this forward in an integrated approach. So, you know, integration is not just for guidelines, it's for it's for life, right? So we need to really do this. So how do we kind of break down the barriers that separate us in terms of the WHO approach? How do we engage community-based organizations of people living with conditions and key populations holistically on a WHO level, but also on a country level? So how can the country offices help introduce the key populations networks to the the hepatitis organizations, who tend to be small, very grassroots organizations without much funding and without much support. And I think that kind of synergies between hepatitis organizations and key population networks could be so powerful, because I think in many, many countries, people living with viral hepatitis struggle to find their voice. I think the stigma around viral hepatitis leads to this invisibility within societies that is completely, not reflective of reality. So I think by working together, we can do so much more, for each other. We can do much more to for our communities that we work with our friends, with our neighbors, with our families, and all the people in those communities that we love. So I thank you very much.
Thank you very much, Kari. And I'm sure that World Hepatitis Alliance will be with us all the way long in implementation of these guidelines. Maybe you have from the audience any questions to Kari. Then I will move to Julia. First of all, we are very glad to be in Spain, and we are. I would like to say our appreciation for organizers and for helping us all the way, and we are very glad to be here. And my question to you as representative of the Ministry of Health of Spain, we are accustomed to understanding that ministries of health are usually dealing with health intervention. It's natural, like prevention, testing, diagnosis, treatment, etc. But we also underline here many times about the importance and the impact of enabling interventions, like changing laws, addressing stigma, discrimination, working with communities, etc. To what extent Ministry of Health can be, useful in this regard, and who actually should lead this work about enabling intervention, please?
Thank you, Slava, and thank you for your expressing your happiness to be here in Spain. It's wonderful to have you all. And yesterday was a very moving and a very special moment for us all. Thank you for your question, because in my experience in these 4 years in the Ministry of Health, I've had time to think about your question. Yeah. What is the role of a Ministry of Health regarding these enabling interventions to go beyond what you are expected to do? Regarding accessing to guarantee access for testing and implement testing, this integrated testing for key populations, it is important that you guarantee universal access to health, because that's the first step. And then you need to understand the barriers that hinder this access in reality, because guaranteeing access, we all know that is not enough. And one of the things that I think I am more proud of being part of this team in the Ministry of Health is one of the first things they did was to change the law and to restore universal access to health for everybody in Spain. And this includes undocumented migrants. And we all know that this is key because you cannot promote testing for HIV, for STIs, for viral hepatitis, if testing is not a way to link people to care, cure them, or get them virally suppressed. So this was very important. But this is obviously not being equally implemented across. And there are barriers. And another important step that I believe our team has done together with the community, and I was really very moved when Keith Sabin and Carrie James were expressing how mature the community is, because this is true. And when we went to the Ministry of Health, the community had a long-standing demand, which was the Social Pact for Non-Discrimination and towards people with HIV in Spain. And this Social Pact had a number of key strategies to be promoted across the whole of the state. Spain is a very decentralized state, so central level, at the community level, and in this conference, the impact at the municipal level also is very important. And one of the important things, and I will stop here because I know we're short of time, is to review all these norms that are outdated, but somehow still are there. For example, in some cities in Spain, HIV positive people cannot have a taxi license. It's ridiculous. Where does this come from? Well, it was there. So this needs to be updated and changed. Until 2018, HIV was a disqualifier to enter the army in Spain. Of course, you were not tested for HIV, but if you were HIV positive and you did not disclose this, you could be in trouble. However, if you were HIV negative, you joined the army, you became HIV positive, you don't lose the army condition. So all this incoherence needed to be reviewed and changed. And if a minister in the Ministry of Health leads and champions the cause, others will follow, because the minister will talk to the Minister of Defense. And where he or she makes a fuss about what happens with HIV in submarines, you just can fight back and you can champion the cause. So I think ministries of health can really be game changers in the response towards stigma and discrimination, which still is the main barrier to stop HIV testing.
Yeah. Thank you very much, Julia. Thank you very much. And we are moving to the opposite part of our great WHO European region, yes, from Spain to Kazakhstan. So, Mira, my question would be, we know that Eastern Europe, Central Asia is the most affected in terms of HIV and tuberculosis and viral hepatitis, many, many problems. From your perspective, from the perspective of the region you represent, which aspects of new guidelines, of new recommendations are the most important for us, for this region?
Good morning, everyone. Thank you, Slava, for your questions. Yes, it's right. It's the Eastern Europe, Central Asia region. Of course, has the highest levels of HIV infection increase, and therefore I think it's critical to address this volatile situation by regular assessment of key population needs. And I think we need to think about flexible and specific program and interventions to the key population. And currently in Kazakhstan, we see that the quickly transmission among MSM groups, and we see that is also a problem with the access to access people who use new drugs, and we see also the spread of the chemsex. And therefore, I think the intervention focus on the target groups will be more important. Is this focus on the comprehensive pack of services, it's pre-exposure prophylaxis and web outreach, peer navigators, and then sexual and reproductive health, STI testing and treatment. And then I see more important will be testing on the community-based and self-testing.
Yeah, thank you very much, Mira. And I also know that, later today, Kazakhstan will present interesting also about Almaty model of HIV epidemic. Can you tell a few words about the importance of, cities and role of the cities in providing integrated patient-centered care for key populations?
Yeah, you are right. Today we will present our projects for all participants. And now I will say a few words about our project. Yes, Almaty is like example of all of the cities. And the project implemented since July 2020 with financial support of Elton John AIDS Foundation, implemented by consortium of local government and community-based organization led by ICAP. It's our aim to focus on people living with HIV and most vulnerable populations. And the Almaty model aimed to improve access to HIV-related services among the key population and to create and implement a cost-effective and sustainable city program which will work to achieve HIV epidemic control in Almaty. And now all our project interventions have been aligned with the human-centered design approach and adapted to the specific of the key population, with specific of our city and the partners' capacity. What about now? We updated our city program on HIV, including some activities which was a result of our project. And I think we will work for people who need us and need us support and helps.
Thank you, Mira. Thank you very much. Yes, of course, please.
Sorry, just before we close, I just want to pick up something that Anton said. We're very excited that for the first time, the Global Fund information note includes support for hepatitis treatment, testing and treatment for key populations as part of HIV programs. So I just want to encourage everyone who is working in a Global Fund supported country, or if your network has members in Global Fund supported countries and your communities are affected by viral hepatitis, to please have a look at the note and please really advocate strongly on a country level for this expansion of services, because again, it just offers us more opportunities to look after the needs of our communities and not just the needs of one specific disease program. So yeah, I just wanted to get that in before the end, so thank you.
Thank you. Thank you, Kari. So we will be closing our session. We are almost on time. You see, like 2 minutes only later that we managed this. I would like to thank all our great speakers, both here and also online. Keith, Annie, Anton, thank you very much. Kari, Julia, Mira, thank you very much. I think that we are pretty much sure that this new consolidated guidelines is the next step towards our, win against these three epidemics: HIV, viral hepatitis, and STIs. And together we can make difference and make healthier key populations. Yes, so thank you very much for being with us, here, the audience, and those who are joining us online. Thank you, and till the next time. Yeah, bye.
Hallo, 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 hallo. Hello.
Hello, hello, hello.
Good morning, everybody.
Good morning.
We will wait another 5 minutes to give the chance to other people to join our session. And yeah, in 5 minutes we will start. So, good morning everybody. Good morning everybody in this room and in the audience outside. Welcome to the session, Democratizing HIV Testing and Linkage to Care Through Community Checkpoints. You maybe not expect two of us, but I would like to introduce myself. I'm Christoph Weber from Berlin. And this is my colleague, Jacques Kohl. We have the pleasure of moderating this session. We are from Berlin, Germany, and work together at Checkpoint Berlin. Checkpoint Berlin is a queer sexual health center in Berlin. Hope you know. We offer HIV, STI tests, STI treatment, PrEP, PEP, among other services. We offer medical and social services in our checkpoint targeting MSM, trans, inter, and non-binary people. We work in a dual leadership, Jacques and me. Jacques is the psychosocial director, I am the medical director. By emphasizing this, that we have a dual leadership, we have already begun the discussion or started the discussion about the checkpoints, because why is it necessary? What are the problems, probably, or the issues? In the last 10 years, checkpoints have popped up all over Europe, in Athens, Barcelona, Berlin, Lisbon, Madrid, Paris, and many more. Basically, one can distinguish between checkpoints that offer tests for HIV, HCV, and syphilis, and those that offer integrated medical care with corresponding services depending on the circumstances of the different countries. All checkpoints are more or less community-based, highly trusted in different communities and highly attractive to people who belong to marginalized groups such as some gays, trans people, migrants, sex workers, and others. Sexual health testing and counseling is still a sensitive issue that requires a high level of confidentiality, security, and safety. Therefore, HIV testing can also be done anonymously. At Checkpoint Berlin, most of the staff are part of the LGBTIQ+ community. Many have a migrant background, therefore we are able to offer different languages to welcome all people from our target groups.
Yes, and also from my side, a very warm welcome to today's session. So I'd like to introduce myself. My name is Jacques Kohl. I'm a psychologist and a therapist, and I do work together with Christoph Weber at Checkpoint Berlin. So for today, we planned that we would like to discuss with you about the Checkpoint's role in the prevention of HIV, in the linkage to care for people living with HIV. And therefore, we are very open to your questions, your impressions, your ideas. And after the presentation we'll soon be hearing, we would like to discuss with you and answer all the questions you might have about the role of checkpoints. So what I want to say to you is that I would like to invite you at the end of the presentation to discuss with us. So feel free to share your ideas and perspective on the topic presented later. So before starting to discuss with you, we have the great pleasure to welcome digitally Miguel Rocha. Miguel is a sexual health nurse at GAT Portugal. He is a public health researcher and health manager. And GAT is an NGO that aims to improve access to prevention, harm reduction, early diagnosis and treatment services to tackle HIV, STI, hepatitis and tuberculosis syndemic by enhancing community participation in services delivery, decision making and research. So right now we look very forward to hear more about your work. Miguel, please, I can see you're ready. The stage is yours.
Hi, hello. Can you hear me well over there?
We can hear you.
Yeah, great. So nice to meet you, first of all, and thank you for the invitation, for being here today with you. Welcome all, everyone attending. Thank you for your attention. I work at GATS. In the past 8 years, I work at Lisbon Checkpoints. So I'm a man who has sex with men. I'm a public health nurse and also an HIV activist. And I'm glad to hear that checkpoints are spreading over Europe. And this is not changing the slides. Oh, I have a button over here. Okay. So checkpoints are spreading over Europe, and probably it's because they work. I would like to see more. In this map, we are seeing that they are more concentrated in a part of Europe. And this map is from 2018. So this is probably outdated. Probably there are more checkpoints by now. They are very alike, but also they are very different, as you said earlier, because they tailor their services to the local context and also to the MSM community values and preference regarding HIV prevention, but they are alike in impacts. So let's start what the impact of checkpoints are having in HIV screening and linkage to care. The checkpoints increase the acceptability and uptake of rapid HIV testing in this population. They have higher user satisfaction. They identify patients at earlier stage of HIV infection, and they are cost-effective in HIV detection. And this is always in comparison with the clinical-based settings or health professionals only teams. So checkpoints are having a great impact with screening and linkage to care to HIV. So when we started 10 years ago, MSM were characterized as hard to reach populations and HIV services as hard to access. And with checkpoints, 10 years later, we are seeing that MSM are testing regularly, have earlier HIV detection and timely linkage to care. How this is happened? To understand better that, we need to see what a checkpoint is first. So what is a checkpoint? Checkpoint is a non-clinical setting in a convenient urban location, providing rapid testing by non-clinical healthcare staff and peers, and referral to and good partnership with specialized consultations. When we read this simple definition, most of people do not grasp the full extent of this change regarding HIV testing and linkage to care. So let's go in depth on that. So non-clinical setting, we are talking about the checkpoints being located in gay venues without the aspect of a clinical facility. So in the picture you see Lisbon checkpoint waiting room. It does not look a clinical facility. In the beginning, people get in our testing center and ask for the towel and slippers. They thought they were entering a sauna. So we do not look like a clinic. And this was really catching for the MSM population. And we are located in convenient urban locations, meaning that we are easy to access by public transportation and that these testing points are located in cities where the HIV epidemics were concentrated. So this was 10 years ago. Fast-track cities were not even a thing at the time, and we already were there. Another big change gamer for HIV testing was the rapid test, because we have a big problem back then regarding the returning of the results. So with the rapid testing, we could provide the result in the same day and start a referral initiation within the HIV testing session. This was also a big game changer with the checkpoint approach. And another thing, and this was a political or a policy change, that's why checkpoint is not a reality in all countries, or not in at least at all cities. That is, the team is non-clinical healthcare staff and peers. This is a clear task shifting from health professionals regarding HIV screening and linkage to care to community. And also referral to and good partnership to specialized consultation. This means that also a change was done regarding the referral from the HIV tests to the HIV doctor. There was a clear and direct route without GPs being involved. And this also was a big change regarding a barrier because there were intermediaries between the results and the HIV doctor that demoved people to getting the first appointment. So we are starting to see why checkpoints work, because within their own definition and approach and composition, they were embedded with interventions that were made to clear any barriers regarding HIV testing and linkage to care. But most of checkpoints began with the MSM population. So where did this MSM appropriation of checkpoints came from? It came from a successful pilot called Checkpoint. It was done in Amsterdam in 2008, and they used for the first time an outreach targeting MSM population with rapid testing. The success of this pilot project was so huge that the first fixed center of a checkpoint used this name because of this project. But checkpoints are not detached from the community response to HIV. And this is another big thing about checkpoints, because they are mostly affiliated to the associations of HIV activists or people living with HIV. So this means that the checkpoints are linked to the local community HIV response, where civil society participation and engagement were ongoing. As an example, in Lisbon, the checkpoint is affiliated to GATT. In Spain, Barcelona, to the Progetto Non Hispanocida. In Sevilla, Avara. In Italy, we have Plus in Athens, and we have Positive Voice for, what is the name? I'm sorry, I don't recall, to name a few. So supported by their peers living with HIV and lived experience and expertise regarding HIV activism, the checkpoints approach is embedded since their roots with human rights activism, healthcare accessibility and tailoring, and also pragmatic activism driven when dealing with all public health stakeholders, meaning academia, public health authorities, health and pharma industries. So these two components, their fundamental core characteristics and their affiliation to the movement of HIV activism with a representation of people with HIV were the main characteristics that made Checkpoint work locally. So what do checkpoints do? They use HIV testing as a cornerstone node for access to HIV prevention. And this is because the prevention services overlap for both people living with HIV and not living with HIV. So we are now seeing the neutral approach regarding HIV status being talked about, but checkpoints are doing that in the past 10 years, that it doesn't matter what the result that you have, we will make access to HIV prevention that you need. Also, checkpoints tailor their services for earlier HIV detection and timely linkage. What does this mean is that it is not only the rapid testing that was in place. There were community interventions to detect HIV even earlier than recent infections, because they promote testing every 3 months, because they promote the knowledge about acute HIV infection symptoms, because they promote partner notification, and because they offer fourth generation tests or the search of the virus through molecular HIV testing, for instance. So all of these put together, checkpoints detect earlier than the other sites and detect recent and acute HIV infections. And this was also a game changer regarding access to treatment. Services are integrated in checkpoints. As previously as you talked about, integrated testing born in these checkpoints, because we learned that when doing HIV testing sessions without the other testing, we were missing opportunities. And also because of some cohorts in place in these checkpoints, the predictors of HIV seroconversion were STIs. So the integration of STIs within the testing session was made there. And now we have ECDC integrated testing guidelines. Peers were enabled and involved since the beginning. And this was a capacity building and engagement with the MSM community with all public stakeholders. Therefore, strong partnerships were built. Another change was the linkage to care and healthcare navigations being provided, meaning that it's not only the referral, but also the booking appointment, going on site, and sometimes even navigation within HIV clinic premises to avoid any barrier. And in the beginning, this was very important, for instance, in Lisbon, because we are detecting a very young MSM living with HIV. But now, with migration in health, this is even more important because of language and cultural barriers, and also because of bureaucratical procedures to access the NHS. But checkpoints do not do only HIV screening and linkage to care service. They are also engaging policy, research, and surveillance. And here is a result of surveillance of the HIV among MSM done by checkpoints. This was presented in 2019 in the HIV conference. And at that time, between 2015 and 2017, 6 checkpoints in the Southern European area were responsible for every 10 in every 100 MSM newly diagnosed with HIV that were reported to ECDC. So we can see that 6 testing points were responsible for 10% of the detection of new HIV cases among MSM in Europe region. Also, they are involved in the policy, meaning that the research that they do and the HIV surveillance they provide are enabling studies even for the economic argument that sometimes is put in place what is cost effective. And in 2014, checkpoints proven they are cost effective in HIV detection than clinical testing sites and detect HIV infections earlier. So the funding should be transferred, the public funding, meaning, should be transferred for these testing sites. And at that time in 2014, most of checkpoints were mostly privately funded, without public funding being the last source of funding. So with all of this, we are starting to see why checkpoints helping democratizing HIV screening and linkage to care session. Because community-based testing, multiple sites for testing, and demand generation regarding HIV testing were the main changes that checkpoints help to do. And with that, and for that to happen, legal frameworks, stigma reduction, task shifting, fundraising, and community involved were all in place to make this a reality. So with this community-based testing, peer-led testing or lay providers testing were made available in a few countries. And with that, the recommendation of WHO regarding the lay providers being integrated in the testing teams, this was because of the works of Checkpoint throughout Europe. And another change is the democratization of the HIV test itself. It began with the clinical sites, and we shift with checkpoints for the fixed center in a community venue, and then outreach mobile units, and later on sex on premises venues. So we are everywhere regarding the HIV tests. And also another contribution was the demand generation with the rapid testing. Because of word of mouth, campaigns, advertising, and partner notification, more and more people start doing tests and more frequently doing it. And because of that, the HIV test is now a routine in MSM daily lives. Another change was regarding the referral to specialized consultations, because there was a direct link for the HIV doctor without any other intermediaries in the process. But also we see a tailoring of the referral with appointment booking, escorting to consultation site, and navigation on HIV clinic premises. And this was to avoid any barriers to access, as I referred earlier. But another thing, it was the HIV doctors in the beginning that were selected for these fast-track routes regarding linkage to care. They were picked by the checkpoints team. And what I'm trying to say is that in the beginning, in the minimum, these HIV doctors need to be gay-friendly, and in the maximum, MSM living with HIV also. And this was also something that in some countries works so well from them to attend to the first appointments, because they feel at ease of talking about their lives and their status. But all of this is not possible without public health stakeholders' involvement. There is a big network of people collaborating for the same purpose, and the community dealing with these public health stakeholders, because it was the community providing their services, but dealing with the public health stakeholders, academia, public health authorities, pharma and health industries, this was very enabling for this MSM community, and this was really capacity building. So in the first, we were more in an approach of accountability, meaning we need more money, or we need change in the rules for people to get tested earlier, or because we need that the referral process to be more or less bureaucratical. But afterwards, with the enrollment of MSM community, also public stakeholders within the team, we see participation and inclusion in a more democratizing way. While doing this presentation, I came across with a study showing that higher levels of democracy are positively associated with higher rates of diagnosis among people living with HIV, even when controlling for country-level expenditure of HIV prevention, HIV criminalization laws, and HIV prevalence. So when we think about democracy leading to more HIV detection, we are talking about this participation within the HIV community response of screening and linkage to care. And when I realized that this is so true and even proved by evidence, if we look back to the map of checkpoints, we see why they are distributed like that. Probably the civil participation regarding HIV response, human rights regarding LGBT, and other stuff related to human rights, access to healthcare, and LGBT rights. It means that checkpoints probably are a proxy of civil participation in the HIV response. That is the presentation I have to show you. Thank you for your attention. Glad to respond to some questions.
Thank you very much, Miguel. Do we have here any questions? Oop. Where's Miguel? He's gone? Ah, here again. Okay, Miguel, I have a question. Would you consider something like the Checkpoint Berlin, where we included a outside practitioners into the concept of the checkpoint? Would you consider this a checkpoint, or would you consider this more or less a praxis or a clinic with social services. You understand what I'm trying to say? So the direction is, in some checkpoints, is more like it's not divided between medical health care and social services. So it's all more together. Would you consider it as a checkpoint in the...
Yeah, I do. Checkpoint, in the beginning, as we saw, it was a team of peers or lab providers providing HIV testing and screening linkage to care. But as we were evolving, we ourselves do not define anymore as an HIV testing center. We define ourselves as a clinical, as a community-based sexual health center. And with that, we are a hub or a platform for people with the same purposes and goals to meet and work together. So we are seeing at checkpoints accommodating the centralized consultations of PrEP, or even hepatitis treatments, or social services, or mental health services because of chemsex, for instance. So it depends on the context and the tailoring that is needed. And checkpoints itself does not have to do everything. We can make collaborations with hospitals, health centers, or any others, but of course they have a minimum requirement of respecting us as a community and involving us in the design of the service itself. And with that, we work with everyone. So checkpoints does not need to be this purest form of all community providing the service, as I'm trying to say, yeah.
Okay, I would agree completely with what you said, because that is, I think we made a step forward when we invented the medical part into the checkpoint, because then we walked in the direction of a one-stop shop, which helps a lot of people who are not familiar with the healthcare system, which are not familiar with the whole system at all, so we can provide them with linkage to care or keep them in care, obtain them in care, which is very important at that level where we are in Berlin, let's say. And I would like to address another question, because what do you think is the role of STI testing in the whole concept of this? Because, to my opinion, it enhances more the needs for people to check for their sexual health. So we can integrate HCV, HIV, STI testings, which I think is motivating, is a good motivation for people to care more about sexual health, instead of having just one disease testing like HIV testing or HCV testing alone.
Mm-hmm. Yeah, integrated testing or multiple disease screening or integrated care. We are seeing this in different areas, and with the learning of this HIV screening and linkage to care, we shift that for hepatitis, for STI, and with that we use STI integrated screening to make the node for access to STI prevention. So it makes completely sense to integrate these services and to be more comprehensive. When we talk about this integrated testing, we meaning that we are access according to their status to different tools that are very important, like for instance, vaccination, antiretroviral disease prevention. So it makes completely sense for me, and I agree with you that integrated and one-stop shop, and as the United States CDC is now calling, is the neutral approach, meaning according to the status, people can go to the same one-stop shop and access services. The difference is that one uses antiretrovirals as PrEP and the other one as treatment.
Do we have any question from the, we have questions from the audience. We have questions from the audience. I'll give you the microphone.
Thank you. One question to the peer involvement. Could you describe a little bit how you find the peers, what you do with them to motivate them working with the checkpoint there, and yeah, what is the role of the peers?
Okay, so there is a question with multiple answers, so I will try my best to answer it. When we involve peers in the HIV testing sessions, they already know the community terms regarding sex, so it's more easy to talk about because the other person knows that that it's also a man with sex with men that is there, so it's more easy to talk about the sexual health and their problems, and for that they are trained with health professionals before, so because we want to have the actualized information. When we talk about peers involvement, we're talking, for instance, support groups. In Lisbon Checkpoint, we have a support group for people living with HIV. So MSM living with HIV that have their infection more than 10 years ago is the moderator, and newly diagnosed people with HIV, they do not have the social support because they're very young, for instance, or because they do not know how to talk about HIV test status, or because they are in a new relationship and doesn't know how and when to disclose. All these things are talked about within this context of self-support, of mutual and peer-to-peer support. Another thing about peers involvement, it means that every time that we have a different team member in Checkpoint, or even a volunteer being enrolled, we see new people coming for HIV testing. This means that the peers involvement bring their own social and sexual networks for testing. And this is another thing that is very good with peers involvement, especially when we're talking about sexual networks that are so smaller and concentrated. That's why the infections spread easier in these populations. So with the peers involvement, we will probably have more people testing from different contexts in the community. More for peer involvement, you may see that when we're trying to translate data, it doesn't mean translate data. They gave you a different meaning of the data that is being available. An example would be in our cohort, we identify different predictors of seroconversion. So we do know that STIs are a seroconversion. We do know that stop using a condom recently with a steady partner was associated with a seroconversion and so on. And so with that information, the peers translate that into counseling. So whenever a guy comes in for HIV testing and they're talking about stop using the condom within their steady partner relationship, they are now added in the counseling about the window period time that is seen in our community as a predictor of HIV seroconversion. And so you need to test both outside of the window period time to be reassured that this does not happen. And this only happens if you have a mutual agreement regarding monogamy or a mutual agreement with a condom use outside of the relationship. So this thing was all talked about and changed because of the science. But this was an interpretation of the peers regarding this science. Yeah, I think I give different examples about the peers' involvement. I don't know if it responds fully, but...
There was one other question, right? Yes.
Thank you, Miguel. I'm Gary Whitlock. I'm a clinician at 56 Dean Street in London. So I've got two quick questions. So the first is that as we're engaging people at Dean Street who are repeat testers and getting them onto PrEP, we're seeing a higher proportion of our new HIV diagnoses who've never been to a clinic before, let alone Dean Street. So the first question is, are you seeing a similar pattern of people who are uptaking HIV prevention and your HIV rates are decreasing? And the second question is, and we don't have the answer for this, how do you target groups who have never been to your service before to test for HIV? Because we're in the situation at Dean Street in London where we're trying very hard to target groups, but we just don't know how to target people who may not even identify as gay men.
Yeah, that's a million-dollar question. There is the population that does not use checkpoint for multiple reasons, and one could be because they do not identify as such, or because they do not know that we exist, because they are part of a network that recently arrived to the country and they are migrants, or just because they use the private systems and never tested with us. But we are not yet seeing that as you are expressing. We do not have PrEP on site, so we make referral of these people to hospitals. Because I believe that if we have PrEP on site, probably we will see different people that never came to checkpoint to appear for the first time just because of the tool itself. So let me see, what should I do? When we start to testing as SONUS, we identified a different population that never went to checkpoint. They were older, they were more likely not being born in Portugal, and testing less frequently. So that's why we have every week testing there, because it's a different population. It's not the checkpoint population. There is more native, younger population. So if you are seeing different people coming from never testing there, I don't know how to do that. Well, we could start first with science. Maybe it's a different population, but belonging from the same sexual networks. So if we do the genomics of the HIV infection, maybe we can see that it's the same type of virus, so it probably from the same sexual network. If they are completely different, they are different sexual networks, so you need to expand your testing sites according to the characteristics of that population. So if they are, I'm just guessing, right? If we are seeing population from a different migrant background, maybe talk with the community leaders or where these people meet. Maybe do inquirers register of these new people that you are seeing. So every testing session with these people to ask where they meet, where they do have sex, and probably provide HIV testing there. More approaches. Yeah, I don't recall anyone and any other by head.
Hi, I had one more question. You refer to these as like one-stop shops. I was curious if you see checkpoints as something that could also integrate different types of screening like mental health, intimate partner violence, and substance abuse that are also relevant to the population of MSM who are coming in to test for HIV and STIs?
Sure, why not? In our Lisbon MSM cohort, it's not a predictor of HIV seroconversion, but we identify a higher prevalence of violence being reported that is higher than in other studies. So we are in the discussion of this, what we need to do, because we are not experts regarding mental health and violence prevention. So it probably would make sense to join with experts and agree in a strategy. It could be at checkpoint or not within the checkpoint premises, but working together to solve these concrete problems in contextual settings, it makes completely sense. So if we have an epidemic of HIV seroconversions due to chemsex, it will be nonsense for our checkpoint not having an on-premises team specialized on that. So integration of different parts of health, let's say like that, It's important to do when we have evidence that this is linked to worse outcomes in this syndemic of HIV, STIs, TB, hepatitis. So for me, it's a yes.
Okay, any further questions? Nope.
I might have one. So first of all, thank you, Miguel, for providing us this very good overview about Checkpoint's work and their history. You were mentioning in your presentation that you were doing some partner notification. I would like to maybe know a bit more about what you're doing. So does it only concern HIV? What are you doing? Yeah, and how do you communicate with the patients and the sexual partners or the partners that person is having sex with?
Okay, the partner notification is a service called Checkout. It's used for all sexual transmitted infections except HPV. So every MSM that is newly diagnosed with the sexual transmitted infection receive credentials for a login in our reserved area of the website. They enter the website, they select the STI they want to notify. They cannot change the wording about the notification that they are sending to their sexual partners. And the notification states that someone who had sex with them has a sexual transmitted infection diagnosis. Call us to do screening and preventive treatments, and then our contacts of Checkpoint. And this SMS or email is sent with our contacts, so with the phone and email of Checkpoint. So the one who's being notified is notified anonymously, and this was to enable recently diagnosed people with HIV that do not feel safe or confident to disclose their status, but also can be used for other STIs, as I said. And this is anonymous notification for both parts. So the one who is receiving the notification does not know who is notifying them. Of course, if the person only has sex with one person in their lifetime will know, but the other not. And also anonymous for the team, because the team, they are all peers, they are all part of the sexual network. So they do not know if they see a notification from who sent that notification. So this is how we do partner notification with the same approach of anonymous rapid testing, anonymous partner notification.
Thank you very much for your answers. I think there's a question. Another question, and then we have to close the session.
Okay, thank you. Just want to follow up on your response re the partner notification. I'm calling Matlodi from South Africa. Interesting enough, especially in terms of protection of personal information, have you observed, especially if ever I'm a person that is anti-clinics and health, and suddenly I get a notification that talks about health screening. Haven't you noticed any increase in partner violence, and also a bit of, how can I put it?
Yeah.
You know, curiosity in terms of suddenly why am I getting these messages? Thank you.
Yeah. So partner notification may lead to intimate partner violence or relationship dissolution. This is registered in evidence. Regarding anonymous notification, this is very unlikely to happen because they do not know who is notifying or when. And that's something that we talk about when people who are notified from checkpoint, from checkout, when they call us, we explain that. So first we start with a positive approach because, oh great, you were notified by checkpoint. You have really responsible sex partners. That's great. When do you receive the notification? Oh, I received this notification. What does this mean? It means that I have HIV? No. Anyone with a sexual transmitted infection diagnosis can send this notification. So it can be HIV, it can be chlamydia, it can be syphilis. So most of them has treatment, and if HIV, if you start treatment, you stop transmitting it. So it's a good thing they tell you about this. So we try to shift that concerning about who or when to what is the purpose and what you can do, because your partners were responsible and engaging with you in order for you to have better sexual health. So, but regarding intimate partner violence, we do not have reports on that with this service of checkout partner notification.
So thank you very much. Thank you to you, Miguel, and thank you to the audience for this very interesting discussion. I wish we would meet again in person and discuss this from checkpoint to checkpoint, because I think there are a lot of things to discuss, either the things with the PrEP or monkeypox, or there are lots of things, and in which direction we want to go for what country. And thank you so much for the discussion, and have a nice day.
Thank you all. Yeah.